the next 20 minutes, so we're delighted to be joined here this year by the Interim Chief Executive of the HSE, Stephen Mulvany. And before taking up this role last October, Stephen was Chief Financial Officer for the HSE, and his career in public service has spanned 30 years plus. So Stephen, you're very welcome.
Thanks,
and
Audrey.
I know that you might have many questions for Stephen, so you know what to do. Go on to Slido and hashtag Health Summit 23, and we'll get them here on the iPad here beside me. So, Stephen, you were here for much of the summit this morning, and you heard some of what our panelists were saying. I suppose if we look now where we're at, we're in February. What's the situation now, as you would describe it, across our hospital sector, coming out of a period over Christmas, before Christmas, and in the weeks afterwards, very intensive overcrowding, some of the worst in 10 years, with everyone really admitting that these were not safe conditions for patients. What are we like now?
So, Audrey, we're not good, but we're better. So the first Tuesday of the year was, as you said, it was the worst on record for patients in terms of delays in admission. Whether you look at the trolley wait or the trolley wait and the surge beds, it was the worst. Since then, and we have to kind of caution ourselves in saying it's not good, but the weeks after that, thanks to all the efforts of the staff across hospital, community, general practice, etc., because we know the ED problem is a system problem that you can't fix in ED, it has been better. It has been, those 4 weeks have been, let's call it the least worst weeks for patients' admissions delays since 2017, if you exclude the 2 years of the pandemic when that issue didn't really arise. So the danger is, as we did last year and previously, is that we get desensitized and we start to think that if the system isn't red, it's good. But there's no good number of delayed admissions, as we know. The system doesn't go into red in the morning until it's 236 patients are on trolleys. Now, if you see some of the conditions some of those patients have to wait, despite the best efforts of the staff, even one of those is not acceptable. So it is better, it is calmer, thanks to the efforts of all the staff and everybody else. But the real decision for us now is where to next for the rest of the year, for next winter. What's an acceptable performance and improvement trajectory? So the stuff that was most impactful in recent weeks, some of it we can't sustain. The parts that we can sustain, we'll seek to sustain. And after that, we'll seek to, if we have to stand some of it down, make it more sustainable so that it's there for the rest of the year.
People will wonder what will be learned from it to ensure there isn't a repeat at the same time next year. And they might think that planning for this year didn't happen anywhere near early enough. What do you say to that?
So, look, people will always ask that question, and it's a fair question, particularly because we publish a winter plan in October. Now, the winter planning starts much earlier than that, and in fact, a lot of what was there this year, as one of the speakers made at a different session, what would the counterfactual position been had the last year's service plan and the years before that not put in the extra 970 beds and all the additional staff across the healthcare system? It would have been even worse. So the reality is the system fell over in that first week, which means we obviously didn't plan well enough. But we would argue that the viruses that were circulating surpassed even our worst, most pessimistic modelling. But the answer is it didn't work for patients, particularly in that first week. It has worked better. The lessons are the after-action review of the recent crisis, which we haven't declared as over yet, has commenced. And the aim is to use that to input into planning for the rest of the year. And what worked best? Diagnostics at weekends, which supported clinicians who do work at weekends, many of them. The community being supported to be able to assist with discharges over the weekends worked well. So there's good knowledge as to what worked, made a difference. The question is, how much of that can we sustain, or else if we have to take it down for a period, bring it back as soon as we can.
There's so many parts of our healthcare system that work brilliantly when people are in the system. But this particular part of it, is it broken?
Well, I think from the point of view of the individual patient, they would probably say yes, it is. If it doesn't work for the individual patient. Now, is that fair to all the staff who are working in the system and doing really good work? Probably not. So, the system sees over 1.3 million people through our emergency departments, but some of them simply wait too long. That's partly because there aren't enough options other than emergency departments, as we know, that the community is not yet fully able to provide enough alternatives. So, as I said, it's a problem that the symptom is what you see in ED. The risk is particularly what's in ED, and that's risk of delayed assessment after triage and risk of delayed admission, both of which are associated with poor outcomes for patients. No getting away from that. So the size and shape of the whole system needs to be changed, which is what Sonticare is about, in order to allow people to only go to ED when they need it. Because if they have no other option, in fairness, people will and should go to ED. The issue is giving them more practical options when they don't need the level of care ED can provide.
I was struck by you praising the staff for getting on top of the situation and turning it into the situation that exists now in the hospitals after that awful period. I don't know if you heard Professor Chris Luke, a former consultant in emergency medicine at Cork University Hospital for many, many years. We were talking about the retaining, the recruitment of staff, and his point was that he doesn't believe that the HSE values their staff. He doesn't believe that the HSE understands what care means and what the carers want and need and how to make them feel valued. What do you say to that?
I think if that's Dr. Luke's lived experience, well, then we have to accept that's his viewpoint. I know some would disagree with him. I think there's more work to be done. Our retention levels are not what we would like. And if we listen to what Ronan Glynn said this morning, we need to work harder and better on retaining staff. Now, we have to accept some staff will always leave. The issue is, why do they leave? Were there reasons that caused them to leave that were beyond simply what they wanted to do for themselves in terms of their own development or travelling abroad? So there is more to be done in that space, because we know that staff who are happy in their work are more productive. It's better for staff, better for patients. If they're using all of their skills, if they're operating at the top of their license, if they feel mastery over what they're doing and feel they can actually provide a service, that's one of the biggest satisfiers of staff. So that's, you have to remove the things that dissatisfy staff, such as paying conditions and terms. That's not the only thing you have to do. You also have to give people what they want. They come into the profession, whatever profession they're in health, to care for people. So if you can enable them to do that at the level at which they're able, that to me is the secret to both retention, but it's also good for the patients, because we'll actually see more patients and be able to treat and care for more patients.
But what is the situation now in the sense of, are increasing numbers leaving the service because of burnout, particularly after the last 2 years, and then what has happened in recent weeks just being the end?
Yeah, I think we are losing more staff. There's no doubt about it. I think the level of turnover this year is much higher than it was last year. The growth has slowed in Q4 compared to previous years. Some of that is people are simply, as you said, tired and burnt out after COVID. Some delayed their retirement during COVID. They would have gone anyway. And some people delayed travel during COVID. So there's a combination of factors. It's no one factor. Are some staff burnt out? Yes, of course they are. But that's not the sole reason for the change. Now, the reality is we've recruited more staff in the last 3 years. I think 15,000 was mentioned. The actual number we've grown the staff from January 20 to the end of last year is 17,800. To do that, we've had to deal with about 9,000 to 10,000 a year people leaving. So we've actually grown the system by nearly 50,000 staff. We've recruited nearly 50,000 staff in order to grow the net number by about 17,800. So there's never been more recruitment. I think retention is definitely, though, as you said, that is the area to put more focus on going forward, because there's only so many staff you'll ever be able to recruit.
How much priority do you give to training, continuous training, education, and those development opportunities for clinicians?
I think the high-level simple answer is a lot, but not enough. That's a very specific question that goes around all you have to look at every single part of the service. So is there a lot of investment in training across the health service? There is. There's investment in training that's kind of cross-discipline, individual disciplines, multidisciplinary training. But I don't think you can ever spend enough in terms of that space. So would we say there's no more to do? Definitely not.
We've been talking a lot today, and particularly this morning, about culture change within organisations, and our keynote speaker, Brian Dolan, has worked in various health systems around the world to try and introduce and implement culture change, and it's not easy. And I'm wondering, is there a great degree of resistance to change at the top level of the HSE?
I don't actually think so, but I sit at the top level of the HSE, so maybe I'd say that. Anyway, but I don't think so. I mean, look, the first question is, why is culture change so important? Culture change is so important because even in a small country like Ireland, the health service and health and social care service is, millions of patient and service users interactions with tens of thousands of staff in thousands of locations across hundreds of thousands of processes and care pathways. every year. It is too complicated to manage in some sort of a top-down command and control type of way. It's too complex to transform by a series of individual projects and programs. So the only way you're going to change it is by changing the culture. How do we do things around here? That culture has to become a culture of patient safety, patient first. We all talk about that. I've been talking about that for 25 years. Could I actually say that every decision I've made as a senior manager the last 25 years in healthcare has always put patients first, starting at the national level all the way down to the shop floor? And let's be clear, RHAs are not the shop floor, they're far from it. No is the answer. So cultural change is going to be one of the absolutely essential elements. But the problem with some of the conversation we tend to have is we tend to pick on one thing that when we have that, we can put patients first and we can actually fix the system or improve the system. The reality is there's no one thing. So culture change is a big part. It needs to be a culture of putting patients first and knowing what that means in every decision that we make. It also requires us to look at the size and shape and the investment in the system. There's no doubt about it. It needs more capacity. But there's loads of evidence that more capacity inserted into the system will not make a substantial difference unless you also both change the culture and change how the system operates. You actually get into some real, because it is a complex system. Therefore, you need to apply, operations management to it, a bit of science around processes. You need to remove all the waste in all our processes. And that isn't about asking staff to move, to work harder or faster or longer. That's about saying, well, are there steps in our processes that actually offer no value to the staff and no value to the patient or the service user? And can we remove those steps over time? Not in a big bang, but the system is so complex, it has to change continuously, incrementally, involving every single member of staff and as many patients and service users and families as possible in what that change should be. Only then can you build a system with that type of culture that actually will sustain change and sustain the continuous improvement. Otherwise, you'll have a series of strategies, implementation plans, projects and programs, none of which individually will actually get us there.
I was struck by something that the former head of digital transformation, who resigned last month, said that he had a strategy to reduce waiting lists put forward. It involved expanding the use of existing technologies and shifting the focus onto on how some chronic diseases were managed and monitored. But he said he had been blanked and blocked. He said the HSE is working with 19th century tools. Do you recognise any elements of that?
Well, I think I said I wasn't going to comment on any individual colleagues, and hello Martin, I know Martin's there somewhere. So thanks for putting me on the spot there. So look, I believe that we do have innovation in the HSE. I think, as we all know, innovation is not just about a good idea, it's about making sure the idea is going to work, that it's going to be safe, and that it can be scaled. And therefore, the relevant clinicians who are going to be responsible for, or managers or whoever it is, for operating that safely at scale across the system need to be engaged. So I think there's lots of examples of good innovation around the system. We signed off one recently there, which involves kind of broadening out the remote monitoring of beds across the system. Very happy to do it. So I think it's not a simple discussion. Could we do more to innovate quicker, to allow people to have permission, as it was said earlier on, to have small failures along the way? We could. Do I agree that there's a kind of a culture of people resisting that change in some sort of a negative way? No, I absolutely don't.
I want to talk to you about Sláinte Care, because that is, central to much of our discussions today as well, and it is supposedly the blueprint for our health service since it was agreed in 2016, 2017. Do you see any indication that it will be implemented in full in the next 5, even 10 years?
I think 10 is probably a better measure of it. I think from the point of view of individual patients, I'd say they would find it hard, and we heard some of that this morning, to say they're seeing progress on Sláinte Care, unless you point out some of the specifics to them. If you're in the system and you can see, I think what a colleague referenced as green shoots, perhaps, you can see individual things which we know are foundational, such as the chronic disease management hubs and the population-based approach, and dividing the country up into 96 community healthcare networks, and trying to build a kind of a geographic view and perspective that looks at local populations but gets them to kind of operate to a kind of an agreed once set of outcomes, as to the what, but then lets the local system and the RHAs, who, as I said, are not the front line, that they're there to support the front line, then figure out the how themselves. I think I see a lot of reason to be positive. I'm in the public service, as you said. I think you were kind. I think it's more like 35 years. Anyway, quite a long time, 25 years in health, and I have a strong sense that Sláinte Care, because it exists, doesn't matter how good or bad a strategy is, it exists. There's no perfect strategy. It has all-party support. It continues to have all-party support. Is it slower than we'd like? Yes. Now, in fairness, it was published in May 17. An implementation plan in May 18 was approved by government, and we've had 2 years of COVID since then. So a lot of the foundational pieces, including the consultant's contract, which hopefully will be agreed by the relevant representative body shortly, a lot of those foundational pieces are going into place. There's strong government commitment to investment. I think some of the missing pieces are that culture that we talked about, and adopting an approach which, as I said, seeks to drive out waste in all its forms, seeks to use a kind of people call it lean or call it systems thinking or operational science, whichever it is, but simply says that wasting staff's time, patients' time, staff's energy, staff's skill sets, and wasting the knowledge of patients, all those wastes need to incrementally, over time, at a local level, as part of continuous improvement, need to be removed. So I think if we can get the culture piece and that bit about, let's just call it removing all elements of waste in the context of adopting a really, really patient-first approach and having a good conversation about what that means, I'd be very hopeful.
But it also removes, it's also about removing those barriers to access, and access still very much depends on ability to pay. So there's no indication that private healthcare, that will end for the majority of people here.
Right. Removing access to emergency care doesn't depend on ability to pay. We know it depends on the problem we talked about earlier. Removing access to scheduled care, to planned care, can, as you say, depend on ability to pay, and shouldn't. And that's the clear policy direction. So there's a lot more work to be done on that. And as I said, it is a combination of investment, but also improving how we use that investment in the best interest of the patients.
But progress, there were no progress reports, as we heard from Sarah Burke earlier, for 2022. What are we to read into that?
I'd have to check that one, as Robert said. I'm not too sure. I've attended 2, if not 3, I think, of those programme boards that myself and Robert co-chair since last October. And again, are we where we'd like to be? No. So I wouldn't measure the progress just in terms of how many meetings we had. Is this year a crucial year in terms of making real progress towards RHAs? It absolutely is. Is it simply enough for the centre to think, what is it willing to devolve to those RHAs? No, it's not. It is about adopting a kind of principle of subsidiarity, where we say, well, if it doesn't need to be done in the centre, it shouldn't be. But equally, if it doesn't need to be done in an RHA, it shouldn't be. It should be done as low down in the system as we can. So if the bigger point is, are we behind where we'd like to be on Sláinte Care? I would totally agree with that. There's some reasons for that. Can't always have excuses. The question now is how quickly we can kind of catch up.
What are the obstacles to reform as you would see them?
Well, so we can name a lot of the individual things which you've heard today. So retention of staff, the whole workforce piece is an obstacle to reform. Data, the availability of it in systems is an obstacle to reform. I think, however, the bigger obstacles to reform are the one I mentioned, which is culture. So none of these individually are the issue, but actually I think the cultural one is probably the single biggest issue. And the single biggest way to address that, in my view, is to say, well, we are going to put the service user or the patient first, not as a trite conversation, but as a hard, difficult conversation to say, what does that mean? Everything else then is kind of, they are barriers. Sorting them is necessary but not sufficient. None of those things, if you sort them, will actually fix the problem unless you fundamentally sort the culture.
Thank you very much indeed. Stephen Mulvany. Thanks, Stephen.